Many people in Ghana have had bad experience at the hand of a nurse, midwife, or other health workers. Many of these cases changed the lives of the victims for the better or worse. On many occasions, the repercussions are dire. Some victims never live to tell their story. In sub-Saharan Africa and Ghana in particular, women still die in childbirth. This is unacceptable. To reverse this trend and promote safe pregnancy and labor, the Ministry of Health, Ghana Health Service and other stakeholders have introduced several measures. But how many have worked? About 130 million babies are born annually. Of this number, over 3 million die within the first 4 weeks of life, and another 4 million are stillborn, and these babies are not counted, and their families grieve in silence. We can bring joy to families if we promote maternal, infant, and child survival with excellence. Let us all promise to save lives. These are the words of the current Greater Accra Regional Director of Health, Dr. Linda Vanutu, who has done so many things to make sure that this dream is realized. These figures, has anything changed?
Thank you very much. We realize that over the years, a lot of effort has been put into saving mothers and babies. And I'm sure you are aware of the Millennium Development Goals that specifically looked at reducing maternal deaths and also reducing child deaths. And because of that, countries all over the world, communities, facilities put in so much into reducing these deaths, which unfortunately occur. So we realize that there has been some reduction, and Ghana is one of the countries that also committed to ensuring that maternal mortality is reduced and child mortality is also reduced. So some work has been done.
So I promised myself to find out more. My journey to know more started with an encounter with a young midwife in charge of one of the CHIPS compounds in the Shai Osu-Doku district. Comfort Abire told me she squats with women in labor because they refuse to go the conventional way.
At my place and here like this, most of them come in labor preferring the squatting position. So when they go in labor, you also go in labor. We squat with them for them to put their hands on our knees. And then they hold you, they use you as a firm support, and then they can push.
Then I learn about how peculiar the Shai Osu-Doku district is. It is part of 16 metropolis, municipalities and districts that make the Greater Accra region. It is the largest district in the region, located on the southeastern part of Ghana. It has a land size of 1,522 square kilometers.
Our district is huge.
Looking at your map,
yes, it's huge. 60,971 population. This population is a population of a sub-district of another smaller district. Yes. So they have to walk distances, and you don't have money to give them. You don't have motorbikes to give them. But I'm really proud of the teams.
Health needs of the people here are like any other across the country. Fortunately, there is a twist to the situation at Shai Osu-Doku district.
At the same time, family planning now, time
I learned for the first time that nurses move from house to house to attend to the health needs of residents. Key among the targets of the Health Directorate here is to ensure that no woman loses her life giving birth. Dr. Kennedy Brightson is the medical superintendent of the Shai Osu-Doku District Hospital.
Okay, so the post-operative cases, they are here. But like I'll say, we don't reject patients. So we have patients on the floor. We have patients on the floor. We do not say that we don't have beds. So when you look at it, it's a student's mattress. And we got 10 from NATMO in Dodo, National Disaster Management Organization. Mr. Ajakli was kind enough to us. We called him. He gave us this. These are post-op cases. We just finished operating them. Do you know? This was the first case, right? Okay. So this is on the floor. We would manage. When I wake up from home and I'm going to the hospital, there is one prayer I offer. And it's like people ask me, so do you pray? I say, I don't pray a lot. I just have a short prayer. So one day I was asked, what prayer is it? I said, God, use me again today to save as many as you want to save.
What a powerful prayer. I like the prayer. It's so short.
It finished. There's a lot of pastors have been receiving them. And it becomes a big problem. So they go for prayers, they don't come for clinicals. But when the prayers get to the peak and what they are expecting does not happen, and death begins to stare at them, then they are rushed to the hospital. We save them. We save them. But we suffer to save them.
Like Dr. Brightson, the Greater Accra Regional Director of Health has her own promise. In 2008, Dr. Linda Amaka Ivanotu developed the PROMISE model. The PROMISE stands for Promote Maternal and Infant Survival Excellence. It was developed out of a desire to identify the reasons for the high number of stillbirths and maternal deaths recorded in the western region of Ghana, where she was the then Regional Director of Health.
So as a regional director, with my team, we had to find out why these babies and mothers were not surviving pregnancy. So what we decided to do is what we call the PROMISE. And PROMISE basically is ensuring that we offer care to pregnant women and their babies, and also involve the families and the community as best as we can. And one of the things that we did was to have what we call the PROMISE drivers. Okay. You know, we've always talked about the 3 delays that contribute to maternal death, that contribute to child death. The delay in the person seeking care, the delay in getting to the health facility, and the delay in giving the care when they have gotten to the health facility. But I realized that there are other things that come in, and it starts even before somebody becomes pregnant. So we're talking about nutrition, we're talking about family planning, we're talking about adolescent health. Because if you want to have a baby, then you must be prepared for it. Yes. If you don't want to have a baby, you should prevent it. So we look at that. We also look at, if the mother comes to the antenatal, what can we do? We need to assess every woman, every pregnancy as one. The fact that I've had 2 children before doesn't mean that when I come, you should just, assume that things are the same. So now what we do is that we try to look at these babies, these mothers, as individuals. We need to look at our statistics. We need to look at the data that we are churning out. We need to look at where we are doing well, where we are not doing well in terms of our audit. We need to have blood available. And then we also need to link public health and clinical care together, because that is the whole health. We cannot do one and leave the other. So we need to do it together. We need to be able to refer. And if we are referring, the place where we are referring to must know that we are referring somebody, and the one we are referring also have to understand why they are going to the next level. Sometimes people are afraid that it means my condition is going to kill me, but it's because of the level of care and what you need to help you to come out with a good pregnancy and pregnancy outcome. And then we also need to mobilize resources. We cannot use what we receive in health alone. There are people who offer care within the communities. There are people who can contribute towards health care within the community. So we need to look at where we can get resources and then prudently manage them to be able to give the best of care. And then we also have to monitor, evaluate, and even conduct research on the work that we do. And then the most important thing, we need to involve the community. So the promise drivers that I am talking about are a set of 12 things that we can do. Each driver has more than one thing in it, and there are several activities. But inside, in the middle, is the community. And the community, we are talking about the pregnant woman herself, we're talking about the spouse, we are talking about the family, we are talking about the systems that exist within the community, which we can use to enhance our health care. And the key thing with the promise is that wherever you are working, you look at your own situation. You look at the kind of things you have around you. You look at the cases that come to you. You look at your capacity. You look at the people that you are working with.
That is from the side of the healthcare.
Yes, the healthcare, yes. And then you design strategy to implement activities that will help you.
Today, she is implementing the promise in the Greater Accra region, and it is catching on like wildfire. One of the modules of the promise is the pregnancy school.
What we do is that we hold meetings with the pregnant women and the spouses or anybody else who matters in that pregnancy. Okay. So it could be your mother.
Stakeholders of the pregnancy.
Yes. Because these pregnant women, as somebody said, hear a lot of voices. The voice from the Ghana Health Service, the voice from another person, the voice from another provider, the voice from even the media where people are talking about issues. And this pregnant woman can be confused and she may not have an opportunity to even ask anybody. So we organize these pregnancy schools outside the antenatal. There you can bring your husband, you can bring somebody else. And we present something, you ask questions. We also do it we have 3 trimesters because pregnancy is 9 months. Yes. So the first 3 months, the second 3 months, the third 3 months. And what we're trying to do is to bring in innovations as we go along. Okay. So for now, we have the first trimester, the second trimester, and the third one, so that we target our education. So if you come and you are in the third trimester, you are getting, yes.
What is specifically
for you?
That?
Yes. Because you are getting close to delivery. So you must be prepared. You should know what to tell you that I'm in labor. You should know what you should do. You should know how to handle the baby. And if you are in the first 3 months of your pregnancy, you may be vomiting. And that will be your challenge. How do I handle
life challenges?
Yes.
It's good to put them
Yes.
in one class and then
yes.
you address them.
And then we address them. So if you have your husband come in, he can also ask questions. We also use the pregnancy school to do some couple counseling. If you have something that both of you don't understand, that's an opportunity for you. It is important to do this because at the regular antenatal, we have so many people, the nurses are overwhelmed. And there's no space. Yes. Right. And since the people come early, we want them to finish and go home so that they can go and continue with their work. So the pregnancy school is an opportunity for you to learn about pregnancy, for you to ask questions. And if you've heard anything, you also, and then it also affords the midwives to know their clients better.
It's exactly 31 minutes after 7, and that's the beginning of my banner, really, because we're talking stillbirths. We have general statistics for 2015. When it comes to statistics, you know that in Ghana we don't do particularly well, but approximately 2.6 million babies were stillborn in 2015, or around 7,200 every day globally. We're told that falls in stillbirth rates since the year 2000 are falling to keep pace with falls in childhood and maternal mortality rates. You can't exactly say the same about Ghana and other African countries. Rwanda is doing something significant, and I know that you have questions, and that's why we're bringing Dr. Linda Van Otu in studio. So very much the interactive session now, if you like. If you've got questions after watching the piece that spearheaded by my colleague Martha Krentel Aqua, you can send me a WhatsApp message. If it's a comment or a question, that's welcome, 0560 800,000. But Dr. Linda Van Otu is Regional Director, Ghana Health Service, Greater Accra Region, and she joins us for this conversation, having personally done some work in this area. So good morning to you.
Good morning, Mama.
Yeah. I hope you're well. Happy New Year.
Thank you very much, and Happy New Year to you too.
Thank you for all the collaborations in 2015.
My pleasure, and thank you for having me.
Yeah. So we're talking stillbirth, but there's something in that research that you did that I want us to perhaps start with. Perception in the community. Yes. What have you found out?
Thank you very much. Let me also say a Happy New Year to all the people here and our dear viewers and listeners. You know, stillbirth, I believe we are going to go more into it, but I tried to look at what the people thought about stillbirth, especially those who have ever experienced a stillbirth. And just to put it in context, stillbirth is when a baby who has been in the womb for 28 weeks or more is born dead. So we looked at our records and identified some women who had suffered stillbirth before and went to them to find out what they thought was the possible cause of their stillbirth. Whether they could have done anything, they thought they could have done anything to prevent it. And then what kind of support they expected from their spouses and from the family and from other people, as well as whether they were happy with the way the news was broken to them. And we found out that some of them said, well, they don't think that they could have done anything about it, because if it is God's will, then they couldn't have done anything about it. Some said that they believed they used a lot of enema, and that is why they had their stillbirth. Some said that they were asked to perform some rituals, but they didn't have the money to do that, and they believe that is what led to their stillbirth. Others did not have any idea. They said that if they had been told by the health workers, they believed that they could have done something. Some said probably it shouldn't have happened because they followed every instruction that was given to them at the antenatal. In terms of how the message was given to them, we realized that there were different ways. For some of them, the message was given soon after the baby was born. Others, it took about 4 days.
As in when the announcement of the fact
Yes,
that the baby
did not survive. Some felt that their pastors should be around when such messages are given to them. And they also said that they needed help with their household chores when they went back home, and that the husband should encourage them and give them money for whatever they needed to purchase. Now, in terms
just to get over the experience.
Yes.
Okay.
In terms of the practices around stillbirth, we observed that when this baby is born, the mother is not involved in any way. Some of them were not even given opportunity to see their babies. And some said that if they had been given that opportunity, at least they will know how their babies look like. Others said they didn't want to see because that might end up with another stillbirth. And then they said that none of them was involved in bathing the baby or preparing this baby for burial. So they don't even know where the baby was buried, none of them. And we also found that any woman who had a stillbirth was not allowed to grieve for more than 2 weeks. So if you want to cry, you have to cry within 2 weeks and stop. Otherwise, one, your next pregnancy may be delayed, or you may have another stillbirth. So these were some of the interesting things that we found regarding the community's perceptions and practices about stillbirth.
Wow, amazing. But let's try and answer a few of them. Almost all of these are myths. What is true and what is untrue about what the community, especially those who have gone through the sad experience, what they had to say?
Well, I think that one of the key things is that we did not have any well-established system for talking to them, for consoling them, for offering that psychosocial support that they need. They would tell you that it is okay, go home, just, in quotes, do some medicine in literal language, and get pregnant soon. You never know what this woman has gone through, and even the husband, because her anticipation was that she was going to have a live baby. And anybody who is pregnant and is carrying the pregnancy is looking forward to a live baby. So that kind of support is not there. And during one of our conferences, I said that I wanted somebody who had had a stillbirth to share her experience, and then somebody who was in the audience, who I did not know, stood up to share her experience. And she said she had had 2 stillbirths, so she had decided never to have another child because she had never received any support. Nobody had talked to her. And that was the first time somebody had expressed interest in her. So you find that that is existing. Again, a lot of them do not even know what caused the stillbirth. Although in many instances we may not find the actual cause. But if we know some of the things that can lead to stillbirth, and we share with our pregnant women and their families, we will save some of them.
Okay.
Yeah.
Let me put this across. A friend of mine, we were almost pregnant about the same time with my first child. She carried the pregnancy for 6 months and she was going for antenatal.
Yes.
She carried for 6 months and then was informed that the baby in her womb had died. And this was a very critical time. I mean, she was buying things, she was looking forward to a baby. Any person that met her on the streets would recognize that she was pregnant and, you know, that kind of thing. You know, Ghana, the way everybody seemed to be interested in you when you're pregnant and all the wishes that they give you. And then they said the baby had died. She didn't want to see the baby. She didn't. So when you were sharing the bit about some people don't take parts in bathing the baby or doing anything, don't even know where the baby is buried. She's one of those. She didn't know anything. The hospital took control of everything. But one of the things I've been asking since that experience is, how come nobody realized or recognized that there was something wrong with the baby? I mean, 2 months, 3 months, 4 months, it had to wait till 6 months, especially when she was going for the antenatal.
That's a very legitimate question. There are several reasons. We have 2 types of stillbirths. We have the macerated one, and we have the fresh one. The macerated one is when the baby dies in the womb.
Okay.
Before this baby is born, more than 12 hours, more than 24 hours before the baby is born. A fresh stillbirth is when this woman goes into labor with the baby still alive. But by the end of labor and delivery, the baby is dead. So there are several reasons. One of the reasons could be infection. In our part of the world, malaria is a very important cause. Syphilis is one. We have issues to do with the mother. It could be elderly people. The books will tell you that over 35 years of age, could be a risk factor. If a mother has hypertension or she has some other disease, that could be a problem. So once you are going for the antenatal, we look for some of these signs, some of the things that could contribute to stillbirth. There's also the issue to do with the placenta, how well this placenta is able to feed the baby. If you have any insufficiency in terms of the work of the placenta for one or two reasons, that could happen. It could even be that the placenta would detach from the uterus. So it means that when that happens, the baby is not getting what the baby should get. There's also the issue to do with the baby himself or herself. And that could be that the baby has some abnormality for which would not help this baby to survive. So it depends on what it was. And you realize that because there are so many reasons, you may go for antenatal today, everything may be fine. But before the next antenatal, which may be 1 month or 2 weeks or even 1 week, anything can happen. So finding the cause may not be so easy. However, you may also have the midwife or the doctor assessing this baby to see whether the baby is growing well or not. Because at every point in time, we know how big the womb should be, how big the baby should be.
Should this assessment not be done at every visit?
It is done. It is done. When you go for the, because we have to write. You see, the antenatal book is like that when you go today, they have to assess how far the pregnancy is. So let's say that it is 20 weeks. When you go in 4 weeks, they have to see whether it is now 24 weeks or it is showing 21 or 22. If it is lower than what it should be, that means that this baby is not growing well enough. And that's when they have to find the reason why this is happening. They also do the scan, and that also helps.
The scan again, in the public hospitals, do they do it at every visit?
You don't have to do it at every visit. You see, those days, when we were in medical school, we did not have this, but we were able to still assess. The scan is not the only way to assess this baby. Although when you do that, you actually see the baby. So you know where the baby is lying, you know exactly if the heart is beating, you know that this is the heart. As opposed to using the earpiece and then listening and maybe counting the mother's pulse and not the baby's pulse. So there are things that we do together. That is why it's not just one way of assessing. So if you go to a health center and they don't have a scan, it doesn't mean that the midwife there who is trained cannot tell you whether your baby is growing or not. But they can use other things like the scan to confirm and also to add on to what they have found with their hands and also using this or even using the measuring tape. So it's not just one thing. So if they are not sure, then they can refer you to the next level. So this your friend, she chose not to see the baby. But some people would want to see the baby. And if you are looking at what happens elsewhere, you find that they actually hold these babies if they want to. Some of them even take pictures, they dress them because they would also have purchased their baby's clothes and all that. So they dress them nicely and take pictures to remember these babies.
But what's your advice? I mean, what do you think people should do?
I think it should be individualized.
Okay.
If you want to see your baby, you should be allowed to see the baby. Although we have had instances where some people have delivered, the babies have not survived, and this has even ended in the death of the mother. Trauma, shock. Some of them have even bled. So it depends. But if the husband or if somebody else wants to see, I believe that that person should be counseled and that person should be allowed if the person feels strong enough to look at this baby.
We'll spend some time on the counseling bit, but let me announce that you can join us. If you're watching, you have any concerns, you can join us via phone now, 030221. Okay, I'm sure my producers will fetch me with the numbers. 0302 211 69102. I took the numbers on holidays. I'm back. 0302-211-69102. Also on WhatsApp, 0560 800,000. 0560 800,000. So you can keep those calls coming through and then your commented messages via WhatsApp now. Dr. Linda Vanutu, is there something that, because I'm sure that when this happens, there are so many questions that you ask yourself, but immediately in the hospitals, do we have counseling places that somebody can take you through, apart from the doctor?
That's a very important question. The nurses try to do their bit and they find a nice place. It could be the matron's office. It could be somewhere else. But let me say that it is not so well established that this is the room where we take you. It is something that is in the offing, which we are trying to establish. When you go to our facilities, you find that they were built, some of them were, in fact, most of them were built many years ago without this in place. That's why we find any good place, any calm place and talk to you. And if the husband is around or somebody else is around, then they talk to them. But we try to do that. And we also encourage them to come for postnatal, even though the baby has not survived, because the mother still has to be checked to make sure. And at those times, they take the opportunity also to encourage them and also to share in their loss, you know. So that is it. But I agree with you that we need to improve upon what we do now to let them know if there's any reason that we have found for the stillbirth occurring, then we need to explain to them. And that's why I agree that it should be at a very good place.
Okay.
Yes.
We'll move to the phone line now. Shaltek is joining us from Tamale. Hello, good morning. Thanks for calling.
Good morning.
Yes, good morning. How are you doing?
I'm fine, thank you.
Good. Let's hear you on this.
Please, I want to find out with the causes of the stillbirth.
Is there some...
Some of us in Tamale, we do right when we are pregnant. I don't know whether that one too can cause stillbirth.
Is this something that you have experienced or somebody close to you has experienced?
No.
Okay.
It says a rumor that people are saying if you are pregnant and you are fond of riding a motorbike or doing some kind of work, it can cause stillbirth. So
okay, sure. That's a legitimate question. Okay, so Dr. Linda Vanutu, if you're riding...
If there's nothing wrong with you and with the pregnancy, you can do your normal chores because pregnancy is actually a normal thing, so to speak. But if it happens that the placenta is down, that means that you have gone to the hospital, they have assessed you, and they've told you not to ride, then you don't have to. Some people, when they are pregnant, you find that they leak the water from the baby, that baby's water comes out, or that the placenta is so low down that if you are not careful, you start bleeding, and that can lead to a loss of the baby or even the mother and the baby. So if there is no reason why this should stop, then it should. But then you should also be careful. If you are riding a motor, over there, some of the roads are very good. In some other places, they are very bumpy. So if you are riding in a very bumpy area where you can easily fall, then of course that can lead to losing that baby. So it depends. It depends. We cannot say that once you are pregnant, do not ride. What about those who are pregnant and drive? So it is a normal thing, but then you have to be careful.
Okay.
Yeah.
Let's hear from Nana from Ejura. Hello, Nana. Thanks for your call.
Yeah, hello.
Yeah, hello, Nana. You're on. Let's hear you.
Okay. Thanks to Dr. Linda. I know she's a very good doctor. I worked with her in Takoradi, so I think she's a good doctor. But on the topic we are discussing now, you see, in Ghana, we have a problem when it comes to nutrition.
Hello, Nana.
Yeah, hello.
Yeah, go ahead, please.
We are talking about causes of stillbirth. Somebody mentioned that. We do not have a clear indication as to maternal nutrition. And people in different communities, like those in the villages, the countryside, people do not have much information about proper nutrition during pregnancy. And so I see, I'm coming from a nutrition perspective. If the country, we do not have a policy on maternal nutrition, things to look at when a woman is pregnant. In fact, we will have a problem because in most advanced countries like South Africa, they have a clear program when it comes to nutrition. Then, when we studied nutrition in life cycle, we don't know nutrition and expect a healthy baby or a live baby. If we don't have a policy, despite a number of measures to prevent infections, if we don't have a very good policies in nutrition, we will always have the challenge of stillbirths, babies dying, we should have a policy.
Okay,
nutrition is not in our system now.
I get you. Nana, thank you. Very, very important points that you bring to this conversation. I'll run it by you, but let me speak to Daniel, who's also joining us. Hello, Daniel. Good morning. Hi, Daniel. Hello, Daniel. Can you hear me?
Yeah, I can hear you clearly.
All right, but you sound rather very low, so kindly speak up for me a bit.
Okay, I'm Daniel calling from Indiana Basanga Central Region.
Okay.
Right. I beg to go to the program that we're having this. This is one of the questions that we should every month.
Thank you.
Looking at what the woman was doing, there are some factors that...
Hello, Daniel.
Hi.
Okay, kindly speak up a bit for me.
All right, I'm talking about some disorders that are associated with age, which may lead some of these disorders, chromosomal disorders, genetics, and the rest. And then I think I need the media. I like to.
Daniel, I don't think this is audible enough. It's difficult for me to hear you. Maybe you can reposition yourself. Let's try again.
All right, thank you very much.
Hello, Daniel.
Hi.
Okay, let's do it again. Kindly say what you were saying. Hopefully we can hear you better.
Yeah, I'm talking about certain disorders related to age.
Okay.
Some to being chromosomal disorders leading to loose things and the rest.
Okay.
And what I'm trying to advise this morning is if the media chance upon this opportunity to talk about the traditional medicine being sold, some quarter participants and the rest, all these disorders, like the woman was talking about social support and the rest. If they are not there, whatever you do at the hospital and the rest, you cannot get the effect under that you're living.
Okay.
And I think it's high time the prayer centers and the rest must also be clamped down. Because at times, see the thing is very a medical case. It's about the prayer centers and the rest. And if possible, Ghana Health Service should rather start forming just clubs than educating them on that matter. I think it will do a lot.
Okay. Brilliant. Thank you, Daniel, for your thoughts. Hello? Dr. Vanusi, let me speak to Regina and then we'll come to you so that you can react. Hello, Regina? Hello, Regina?
Yeah, hello.
Yes, Regina. Thank you for your call. Let's hear you.
Yeah, hello.
Hello, Regina. We can hear you here.
Yeah. Yeah, I would like to ask whether I'm 7 months pregnant and my tummy is like, quite small. And I would like to know whether is that...
Oh, we lost you, Regina. Okay. But I can conclude for her. Should she be worried that her tummy is quite small even though she's 7 months pregnant?
Okay.
Yeah.
Let me start from the nutrition. It's very important that we talk about nutrition. And that is why at the antenatal we talk about it. We have anemia. Anemia meaning that the blood in the pregnant woman, not the one we measure with the sphig, but the one that they test in the laboratory, the red blood. We find that for a lot of pregnant women, it is low.
Yeah.
That means that the nutrition and other things that will lead to anemia are high. So the nutrition may be poor. People may be eating all sorts of things because of some misconceptions that they have. For example, some people believe that when you are pregnant, you shouldn't eat egg because your child will be a thief. Some people believe that you should not eat red meat. You shouldn't eat this. Some of the things that will help you to be well built and be healthy to go through pregnancy, people do not eat them. As part of our work, we actually looked at what pregnant women eat and what they do not eat. And one of them, for example, was that you should not eat rice. You shouldn't eat ripe plantain. You should not eat certain things because the baby will be lazy. And when you get into labor, you also be lazy. So there are so many misconceptions about what you can eat when you are pregnant and what you cannot eat.
You know, that's interesting because in my case, I wanted to eat, but I didn't know what I wanted to eat and I didn't have the appetite for it.
Yeah. That is why now we are improving upon our antenatal. We have the focus that you can be alone with the midwife and you can ask questions. That is why we have introduced the pregnancy schools, as you saw. Those are the places that we can also demonstrate to the pregnant women what is locally available and nutritious that they can eat. It is very important that when a pregnant woman is eating, she eats food that is good. But when they get home, there are also the issues about what is available and what is not available. There might be things that are available that she can eat, but she may not be used to them. There's also with the Ghana Health Service and the ministry, the anemia prevention. We have that in place. Unfortunately, some people, when they are even given the tablets to take, refuse to take them because it is said that it will let your baby be big. And that means that when you go to deliver, you will suffer.
It'll be difficult.
Or you will go through a cesarean section. So I agree with him that we need to improve upon our nutrition in pregnancy and let people know what is locally available. We have fruits, we have vegetables, we have all sorts of things around us.
Sometimes the smell of something.
Yes.
You don't want to eat it.
Yes, so if this one is not good, maybe another one is better for you, so you can eat that. So there should be the options. And I believe that what we could do with the nutrition unit with my dear friend is that we can also have things written. You know, we try to look at what our foods contain so that our midwives will be able to use them and then tell them the quantity. So it's not enough to tell a pregnant woman to eat maybe beans. How much should I eat? If I'm eating contemporary, what should I do? So I believe we need to have the nutrition unit also coming in and probably writing simple things that we can use in our places to do this. Because
of time, the questions that I have, lots of questions on WhatsApp. If there is a simple way of answering them, I would appreciate it. Hi, please, can pelvic inflammatory disease cause stillbirth and can it cause infertility?
Yes, it can.
Okay.
Yeah.
All right. Let's move to the next one. Oh, okay.
But whilst you're looking for it, the chromosomal things, you cannot see some of them with your naked eye. And that's why I said that for some of them, they have abnormalities. The babies have abnormalities that may not be compatible with life. And that is why it will end in a stillbirth. And for some, when the baby has passed, we need to do further analysis. And I just wanted to add that we even have audits that we do. Time will not permit us, but let me just also answer the traditional medicine. It is very, very, very important. For some of the pregnant women, when they go for the antenatal, they are fine. There are a lot of things that they use. One of them is what they call our mortality. It's supposed to help labor be easy. Unfortunately, it also leads to incoordination in terms of how the uterus contracts. And therefore, this baby goes through so much stress and dies. So you find a woman who has gone through pregnancy, she's fine. Maybe another time I'll share with you the work that we have done with this awomrel. And in the north, they call it agotime. There are so many places they use different things. Yeah.
Philo is asking, please, at what point in time should pregnant women take tetanus injection? I'm 5 months now with no tetanus.
When you go to the hospital, you see, as a woman, as a female, we start when you can have a child, not when you are pregnant. And once you have had 5, that is it. So if in the previous pregnancies they have given you, then you will not need another one. If you have had 2, 3 children, the next one they will not give you. But because it is something that has to be given at the hospital, I will advise her to go to the facility where she goes for antenatal, ask why she has not received it, so that somebody will not say that I'm this number of months pregnant, I've come, give me. And they have to go through and see whether you actually need it or you don't need it.
So ask questions. I experienced stillbirth at my first pregnancy, but I now have 2 children. After that experience, I took very good care of myself during my next pregnancy, especially nutrition and sleeping under treated nets, because I couldn't bear the pain. I didn't even look at my dead baby. Thank you very much for sharing this experience.
That's very important. You see, we give the prevention for malaria at the hospital. You take it there. But some people do not want to take it. And malaria, as I said earlier, can contribute to stillbirth. So it's very important.
Is there a difference between stillbirth and miscarriage?
Yes.
Okay.
Yeah.
You would expand on that, but let me absorb my questions. I don't want anybody to say I didn't read their question. Good morning. As much as we try to help reduce stillbirth, we need to pay attention to the rural areas and ensuring that we have midwives to attend to our pregnant women and educate them as well. It's from Matilda Adope. Sending me that message. Forgive me if I didn't pronounce your name well. Good morning, Mama V. I'm Enoch, a nurse at Kokofu Government Hospital. I think we need more competent midwives in the service who will educate the women well in all aspects of that period. Stillbirth by now should be a thing of the past. I do agree with you. I think we should encourage pregnant women to access services and provide holistic care for these expectant mothers. And it's from Phyllis in Kumasi. I appreciate this. This one says, please read my question and answer. My wife had a miscarriage, but for a week now, she's still bleeding and the tummy is still becoming big. What should I do? You can merge this with a stillbirth and miscarriage.
Okay. Miscarriage is when the pregnancy has come out. You know, I told you that it's 28 weeks pregnancy and more. Then it is a stillbirth. Miscarriage could be when she's 2 months pregnant or 3 months pregnant or 4 months pregnant when it ends. Now, if the wife has had a miscarriage and she's still bleeding, it is important to go back to the hospital. It depends whether the blood is red or it is not red. If it is red coming still after so many days, it is possible that there might be something left in there. It could be a little piece of the conception, the pregnancy, that is then has to be taken out. It is important because blood is a good medium for bacteria to grow. And if you are not careful and she gets infection, and he says that the tummy is becoming,
still growing.
Yes, bigger. It means that they have to go back because the uterus at this time should be getting smaller and not bigger. So if it is becoming bigger, then they need to go back as quickly as possible.
All right. This one says, my good mother took her time to explain to public. This will encourage us to send our wives to hospitals, but some hospitals, the nurses are not treating our wives well. Some are shouting on them whilst they are in labor, and some are beating them, especially with those in remote villages. And I'm a witness to that. Some hospital in the pregnant women said that's her last. Like, okay, I mean, it's a bit, but I guess it's the same. We've had this conversation before. The treatment that some people receive from nurses that discourages them from going forward, even when they have issues. This one says, hi, Mama V. Say kudos to your guest. Stillbirth is increasing in a high rate, and I want to plead with the Ghana Health Service to do something about it seriously because the innocent mothers are suffering too much. It's from Indebugri Simon in Zibala sending me that message. Okay, let me go back there.
To that we have developed an audit form. So we audit our stillbirth. We audit babies who die soon after delivery as well. And this will help us to identify the real causes of this. You know, stillbirth, I told you we have two, the macerated and the fresh. And the fresh ones are the ones that the women came into labor with the babies alive. So it is very important that once she has come with the baby alive, she goes home with a live baby. So we are doing this auditing to find out why did this baby die, even though the woman came with the baby alive. And that will help us to also pull out the gaps in our delivery. So if it is that the midwives need more training, If the baby is coming with the buttock, that is another reason, one of the things. You deliver this baby who should have come with the head, but is coming with the buttock. And at a point, the shoulder or the head gets stuck. If you don't have an experienced midwife, then she now needs to call for help. By the time the help comes, this baby might be dead, or the baby may be too big. So we are looking at why these babies are dying at the time that they are being delivered to find out. So we have audits that is ongoing now.
Okay, this one says, hi Mama, I was a victim, but I tried to get pregnant for a year now, but not yet. I want to know. It's from Clotilda in Bolga. Kindly hold on to that. Good morning to you and your lovely viewers. My problem has to do with the... Okay, that's why you're going back to teachers' issues. Hey, Charlie, my wife had stillbirth, and I'm very angry because a lot of care and preparation was done. What is the cause? Okay, so you can box this up with somebody who had a stillbirth, been trying to have another child for a year. How long should it take you?
It shouldn't take any time. You see, it depends on how well she was counseled, how well she feels that she can do something about it. It is possible that she may be thinking that it's her fault. It is possible that she still has that in mind. She may need to go through some counseling for her to know that you can have a live baby even after the stillbirth.
Sure.
Yes, and both of them, she and the husband, once she's having her menses and all that, it is possible. So she should forgive if she thinks that it's her fault. She should forgive her. She hasn't done anything
wrong. Take her mind off that experience and just move on.
If it is too much, then she will need a counselor to talk to her about that.
Okay.
Yeah.
The last message I read, there's actually a beginning to it. It says, I had a stillbirth this December, after which I had EOU again. There was no counseling. I couldn't get opportunity to ask questions. I want to know if I can have another baby. That's the message that ends with the person being really angry because they have done a lot
you can have another baby. Remember that the one who said the tummy is growing, is becoming bigger. I said that there might be something, then it has to be removed. And that is why this EOU was done, so that we are sure there is nothing in there that will cause bleeding and that will cause infection. The person can have another child.
Okay.
If it is that the person wants to know, he has every right as the husband to go to the facility and ask. And when he gets there, he can look for the head of the facility. Every hospital, every health center has somebody who is in charge.
Okay.
So they can go there, they can look through the records and see if it is something that could have been avoided.
Okay.
Then it will be explained to him.
Sadly, we have to end this conversation here, even though I'm getting so many messages. We will probably have to continue. MFA Kekali in Tema says, hi, Mama V, we need this education on TV daily. We don't have to wait till prenatal before women are blessed with pregnancy, nutrition, and education. They should take all those unimportant adverts from TV and replace it with pregnancy education. I get you.
The last about the baby, the one who says she's 7 months pregnant and the tummy is still small. Yes. On her own, she may not be able to say whether the baby is growing at the rate that it should grow or not. So I suggest that she goes to the hospital, talks to the midwife, and they will look at how this baby has been growing. Through the assessment, they will know whether at 7 months, it is whatever number of weeks. If you go and you believe it is 7 months, but they look at when you started and see that it may be even 6 months or 5 or whatever, they will tell you. If it is that the tummy is smaller than what it should be, then we have a growth restriction whilst this baby is inside, and we have to find the reason.
Okay.
Because it's very important that you have a baby who is the normal size.
Okay.
Yeah.
All right. Hajara is asking a question. I had 2 miscarriages before my firstborn, and my next also. I had another miscarriage. What caused that? Hajara, I'll tell you what Dr. Linda Vanuatu would tell you right now. Please go back to the hospital and ask all the questions that you want to ask. So many messages on this. I'll come and read back to you. But Dr. Linda Vanuatu, I am so grateful for your time. This is our first experience in 2016. There are brighter days ahead.
Amen. Amen.
Thank you.
My pleasure.
Coming up next is AM Talk. Stay with us right here on the AM Show.